Probably state of the art back then.
Allow us to present Mr. and Mrs. Josiah Smith, average Americans of a half century ago. Younger than the average Americans of today, but then their chances of growing to a ripe old age were clouded with many threats.
Okay, so it's funny because a lot of those diseases, especially in North America, are no longer relevant. I meant smallpox has been almost eradicated, or has been eradicated, except for when we think about bioterrorism. Typhoid, I think it's only when you travel. So just interesting to see what old threats to your health were.
In the last 50 years, the sky has been cleared of many of yesterday's perils, and today the average American lives longer. But it's well recognized that medical science, while helping him live longer, pretty fair on the whole. But while there's very little smallpox now, there's plenty of high blood pressure.
So this is actually something that is true today. Yes, the threat of diphtheria is no longer prevalent, but yes, heart disease is still one of the most common things that, as physicians, we need to treat. Looking at somebody's cholesterol over the age of 40, definitely prevalent, something I do every day. So that is 100% true.
And along with it, troubles of the heart, kidneys, and blood vessels, and other problems of a constantly aging population. For the control of many of these conditions, early detection is important. Therefore, recent years have seen increasing interest in mass screening devices. For example, diabetes detection drives using blood sugar tests or urine sugar tests have been tried in many communities. The idea is to screen apparently well people not already under their doctor's care. Objective tests are used. Those with sugar findings above a specific standard are referred to their physicians.
And that's true, especially in the primary care setting. One of the things you definitely have to do is make sure you're up to date in all your screenings. For example, I mean, every patient that comes in for their annual, I make sure that they have their colonoscopies, pap smears, that they have their mammograms. You do screening for diabetes, depending on certain risk factors. So it's 100% true in this video. Osteoporosis after a certain age, all your vaccinations. We also test for cholesterol, um, depending on certain risk factors. PSA, which would be your prostate, is something that's also tested for. So there's many health screenings that have to be done, and then these just show to reduce risk of cancer in certain populations.
But to avoid the duplication of effort in screening 1 month for diabetes, another month for tuberculosis, and another for syphilis, the question has been asked, why not combine various screening tests? Instead of many separate screening lines, why not combine them into one, multiple screening? Multiple screening makes use of a series of technical tests, each taking less than 3 minutes. Multiple screening does not involve diagnosis. For example, if blood is to be taken for a syphilis case-finding project, such blood samples can also be examined for diabetes and anemia.
So yeah, this is extremely common now. I guess it was more novel back then. We're talking about 1950s Phil, but yeah, you do multiple screenings in the annual exam, and you look for several things. Syphilis, not part of the normal screening, but if you had increased sexual risk or exposure, yeah, you would definitely do that. Um, but it makes sense, and it's something we do now all the time.
This is multiple screening in one of its simplest forms. If it is decided to add X-ray, the X-rays can be read for tuberculosis, for certain heart abnormalities, and even for lung cancer. If it is decided to use urine,
I have to pause it here because it's interesting that we were talking about chest x-rays for lung cancer. And it was only actually recently that we started screening for lung cancer under certain populations, and it's usually smokers who have smoked for over a certain amount of time and have an elevated risk and have not quit within 15 years, that we start screening for lung cancer, and it's actually done with a CT scan. Um, and that's just been shown because people who smoke for a certain period of time, who haven't quit, do have a higher probability of having lung cancer. It's not part of a general screening. So it's just interesting that they say this in the 1950s.
Sugar tests for diabetes rather than blood sugar tests. The urine can also be examined for nephritis. Other tests that can be added are height and weight, hearing and vision tests, blood pressure tests, oral examinations, and perhaps electrocardiographs.
So just another thing, electrocardiograms or EKGs. It's not necessarily that you screen every patient that comes through. It could be by case. It could be based off history or some kind of symptoms, but it's not like a blanket screening thing. And a lot of time, these screenings come from governing bodies, especially internal medicine. We have a couple that we look at, but one main one, and that's just not part of it. There's no general cardiac screening that's done, like on a general population.
New tests can be added as they are developed. A community can select almost any combination of tests it wishes. In one rural program, 2 tests were used. In an urban area, 4 tests were used. In another urban area, 7 tests were used. This is a matter for local decision. Each community can develop a multiple screening project to suit its own needs. The personnel needed for multiple screening includes some administrative personnel, laboratory personnel, and the personnel at the testing center or centers.
So what he's hinting at is a little more nuance. And so screening has a lot of things. Yes, there's the population, but there's also healthcare dollars. So, for example, you might wonder, people come to the doctor or people come to me and they will say, "Oh, test me for everything. Test me for all the hormones." And I'm like, "What do you mean all hormones? I mean, there's hundred thousands of hormones in your body. There's no general screening for all your hormones." Or people will come and say something like, "Oh, can you just scan my body from head to toe?" And you'd probably think, what's the problem with scanning somebody from head to toe? There, and there actually is several issues. The first is healthcare. The first issue is healthcare cost, right? So imagine an insurance company having to pay for a CT scan or MRI for you to go to head to toe, everybody in a population or everybody that is under that insurance. Well, it's going to cost a lot of money. And then you have to think about it's costing this much money to reduce what risk. And so you have a risk analysis benefit, right? If you screen 1,000 people, you screen 10,000 people, how many people are you finding with something? It gets even more complicated that when you scan all these people, it's what do you find? A lot of times in medicine, we have these things called incidentalomas. So essentially, you screen somebody, and let's say you just find this mass, and now what happens? You have to investigate that mass. So you scan somebody head to toe, found a mass, let's say in their stomach, and a lot of times people can go on with these masses, and a lot of times they might be benign. But because you find it, now you're going to track them. Now you're going to have more follow up. Now you're going to get more exposure, more radiation, more testing, seeing your doctor more often, and at what cost. So that's why you generally don't screen. So there's a calculation in what's good for the population, what's good, what risk factors do these patients have, how many healthcare dollars are being found, what's the risk benefit analysis. So that's just a little something.
An average testing center needs a receptionist, several technicians, several clerks, and a supervisor.
I also find it interesting that all the women are wearing the exact same thing in the office. I mean, this is very 1950s. Mad Men. Mad Men.
These can be arranged in any convenient order. Such a testing center can screen in one day several hundred Mr. and Mrs. Joe Smiths. Mr. Smith arrives. The tests begin. Each test must be inexpensive to use, as specific as possible, and quickly done. Joe Smith spends only about 3 minutes on each test in the screening line. Technicians do the testing. At the end of the line, he is reminded that any positive reports will be sent to his own physician. This
Just something else to hint at. What they're talking about is screening, not diagnoses. And that's something that happens all the time in the clinic where somebody is screened for a test. The test may come back positive, but again, it's a positive screen, not a positive diagnosis. So, for example, a lot of times people come in with multiple joint pain. You might screen them for autoimmune disease. They come back with what's called a positive ANA or a positive possible autoimmune test. What does that mean? It just means the screening has identified them as possibly having a disease, not actually having the disease. And so in medicine, it's important to explain to patients that you have a positive screen, not a positive diagnosis. And then I have to tell them we're going to undergo further testing, or I'm going to send you to a specialist for further analysis.
This saves the most highly trained type of personnel, the physician, for the later work of interpretation, diagnosis, and treatment. Thus, through multiple screening, economical and effective mass case finding may be provided in any community. From the general population, the tests screen out those who appear to need medical supervision. These are referred.
Right, exactly what I was talking about. So you do a mass screening, and now you have what's left is people who possibly have a disease who need further analysis
to their own physicians. A few of them, of course, may be found by their physicians to be well. The others will be diagnosed as ill and treatment begun.
100% true. So back to the previous case I was talking about where patients are screened for a positive autoimmune. A lot of the patients who I have tested for autoimmune might have a positive ANA, and on further testing, no disease is found. So again, this helps to show that screening doesn't equal diagnosis. It just means that there's a certain population of people that need further analysis.
Multiple screening can channel to physicians people with unsuspected serious diseases or minor disabilities early enough to stabilize, if not actually to correct, the condition. Many late complications can be avoided through early diagnosis and treatment. The private physician of today, because of the rising importance of the chronic diseases, is in a dilemma. Watching the stream of humanity passing his door, he knows that in his community there are unknown cases of tuberculosis, of diabetes, of syphilis, of glaucoma, of heart disease. He knows that...
So all this is true. I mean, they keep mentioning tuberculosis, and that's just not that common in the United States. Usually it's like immigrant population, somebody has exposure, maybe somebody who's been in proximity to others, like patients in a prison. But tuberculosis isn't a high in the list of things that we come across daily.
Many of them will not of their own accord seek medical attention until disease has won a firm foothold. He also knows that if he could find and treat them at an early stage, he could help them. What can the physician do? Ethics forbid him to put up a sign, to warn or persuade them. He cannot seek them out or call out to them. He must stand aside and remain silent. But multiple screening as a community project can do what must be done to combat the chronic diseases. It can turn some of the people, the ones in need of early attention, back to their own doctor's door. So the idea of multiple screening is to use mass screening devices on people in general,
in this video.
people who feel well, to bring unsuspected cases to their own physicians early enough to prevent complications or crippling illness. Early enough.
That is the most old-timey doctor I have ever seen. Like, it's funny because when patients come and see me, that's sometimes what they expect to see. Um, and it's also true that patients definitely trust older doctors than younger doctors. I think there were some studies on that.
to protect their health while they have it.
I mean, so that's pretty much the video. It's just interesting to see a video from the 1950s and see them talk about screening. I mean, obviously, there's some things that are still prevalent today. I mean, screening is 100% important. And, you do find, as a physician, you do find that some patients have positive screens and you do catch diseases. I think the diseases we look for and how we look for them have definitely changed, but it's definitely important in the primary care setting.